Hello, my name is Yusuf Salibi. I am a functional medicine physician practicing in North and South Carolina, and today I'm going to be tackling the topic of naltrexone and erectile dysfunction. Disclosures and conflict of interest. I want to disclose that I am the director of a nonprofit 501c3 teaching academy called Priority Health Academy. I'm also the medical director for the Carolina Holistic Medicine Centers. I'm also a member of the Medical Advisory Board for the LDN Research Trust. Nothing to disclose and no conflict of interest for this presentation. The objectives for today's lecture are to understand the research and lack of behind naltrexone and erectile dysfunction. Also, how LDN may be helpful in erectile dysfunction. The theoretical, physiological, and biochemical effects of LDN and naltrexone on erectile dysfunction. And the best delivery systems for naltrexone with those suffering from ED. Also, we'll look at an understanding of the fact that there's very little research that has been done using low-dose naltrexone in the realm of erectile dysfunction. And then I'll finally be wrapping up with a couple of case presentations. Because the importance of evidence-based medicine these days in lectures and presentations, I'd like to discuss a little bit about evidence-based medicine and how we should characterize this. What is it? If you have high quality research evidence, it seems to play an important role. So the dynamic integration between what we have is research from peer-reviewed journals versus that of clinical experience and patient values, we need to kind of look at this in perspective. In some cases, you have one study contradicting a second study that appear in two different journals 2 weeks apart. So we have to sometimes, when we don't have high quality research evidence, we have to then rely more on our patient values and the experience. That has to factor in a little bit more. So that being said about evidence-based medicine, I'm going to present a few published papers. The first one is a study that used 50 milligrams of naltrexone for erectile dysfunction. Now, this conference is on low-dose naltrexone, but a lot of the research I'm presenting has been done with higher doses of naltrexone, and we can take away some things from these cases. So this paper was published in Psychoneuroendocrinology back in 1989, so it's an older study, and it took 30 male participants with sexual dysfunction between the ages of 25 and 50 with idiopathic impotency, not due to any organic etiology. And the patients received either 50 milligrams per day of naltrexone or a placebo in a randomized fashion. Sexual performance expressed by the number of full coitus encounters per week was assessed before, that's time 0, and then during the study, which was on day 7 and then again on day 15 of each of the treatment arms. The naltrexone therapy significantly increased the number of successful coitus compared to placebo after 7 and 15-day treatments. Improvements in 11 out of the 15 treated patients was observed. All the patients experienced a significant increase in morning and spontaneous full penile erections per week. Endocrine studies reveal that there was no significant modification in plasma LH, FSH, or testosterone by naltrexone. Therefore, the positive effects of the drug on sexual behavior and erectile function was exerted in a central level, not with the hormones. 2 months following this study, the patients were again off treatment, but were followed up, and it was noted that erectile capacity had returned to baseline in 10 patients, while 5 reported complete recovery of their sexual ability. In this study from the Journal of Andrology from 1993, we see the use of, again, higher doses of naltrexone, in this case the doses of 25 and 50 milligrams. The study looked at the treatment of idiopathic erectile dysfunction in men with naltrexone. It is known that opioid antagonists can indirectly stimulate the secretion of luteinizing hormone and testosterone, as well as sexual functions in both animal and human models. In this study, 20 otherwise healthy men with idiopathic non-organic erectile dysfunction with an average age of around 46, give or take a few years, were entered in this double-blinded study with naltrexone and or placebo. The erectile dysfunction of these men had persisted for over 3.5 years on average, despite libido maintenance, standard procedures that excluded any sort of organic causes. The trial duration was 12 weeks, where after the first 4 weeks of a kind of forerun period, the patients were either administered 25 milligrams of naltrexone orally per day or placebo. This was followed by 4 weeks and then another 4 weeks where either 50 milligrams of naltrexone per day or a placebo was administered. Each day the patients filled out a questionnaire detailing libido, degree of erection, frequency of sexual intercourse, and morning spontaneous erections. Serum concentrations of gonadotropins and testosterone were also collected in the initial and at the end of each phase. Both patient collectives had similar initial factors. The group treated with naltrexone showed a significant rise in spontaneous early morning erections during the treatment. The placebo group showed no significant change in spontaneous erections. The subjective parameters, however, such as libido, degree of erection, and frequency of sexual intercourse, showed no significant difference within each group. There was, again, no difference in LH, FSH, and testosterone concentrations in both groups. Therefore, it was determined that treatment with naltrexone significantly raises the rate of spontaneous early morning erections when compared to controls. And again, this is one study from the early 1990s that had some sort of mixed reviews, a little bit unlike the first study mentioned. In yet another study using 25 milligrams of naltrexone, we see in this a little bit more recent study from 2001 in the Archives of Medical Research that naltrexone can augment sexual response in men. Naltrexone was used and its effects were documented with select self-report measures of sexual response to masturbation that was recorded in all the trial participants. So they selected 20 healthy sexually active men with or without partners, somewhere between the ages of 20 and 29 years. And they administered 25 milligrams of naltrexone per day for 3 consecutive days. Or in the placebo arm, they did not. And this was a double-blinded crossover design study. There was at least a 14-day interval between drug and placebo treatments, and between 18 and 22 hours after the most recent dose of either the drug or the placebo, subjects were able to view sexually explicit videos in privacy for at least 2 hours. They were also instructed to masturbate or have as many orgasms as desired. The following 3 different self-report measures of their response were recorded, and that is the number of orgasms, the intensity of the sexual arousal, and also the orgasmic intensity. Under the naltrexone conditions, the volunteers experienced a significantly greater mean number of orgasms than those in the placebo group. The total number of orgasms was 67 under naltrexone conditions and 51 under the placebo conditions. At the first orgasm, the measure of intensity of arousal was significantly greater in the naltrexone arm than the placebo arm. And the measure of orgasmic intensity was significantly greater in those taking naltrexone. This study basically provides evidence that endogenous opioid modulating orgasmic response and the perceived intensity of sexual arousal and orgasm in men can be achieved with naltrexone. Therefore, naltrexone, at least in the dose of 25 milligrams, is useful in inhibited sex desire and erectile dysfunction. I want to present now some clinical observations and some presentations made by Dr. Mark Schuchman. Dr. Schuchman is a psychiatrist who practices in Ohio, who has a focus in his practice on sexual dysfunction in both male and female patients. He uses naltrexone and LDN specifically in a lot of his patients, and in a lecture presented in 2016 at a LDN conference, he actually presented on naltrexone and its effects on sexual dysfunction and erectile dysfunction. So these are notes taken from 2 of his lectures that he presented. And also in March of 2021, I had the privilege of having a fairly lengthy conversation with Mark on anything new and exciting since 2016 that he's aware of. And so a lot of this material will be presented borrowing from some of his slides and also our discussion in March of 2021. We know that opioids block endorphins and increase inflammation and reduce arousal of erectile function in men. So in theory, blocking opioids with naltrexone may have an effect to increase endorphins, reducing inflammation and increasing arousal. Endorphins, when timed correctly, can enhance the effects of erectile function. So while the use of high-dose naltrexone may lessen the urges of sexual addiction, LDN timed correctly with doses, lower doses, and what we call chronopharmacology, the timing of it, can enhance it. We want to raise the oxytocin effect. We also want to lower prolactin, and again, we want to raise testosterone levels, if at all possible. A drop in dopamine will actually increase oxytocin, and we see a drop in dopamine after orgasm. It sort of builds up towards that, but once orgasm has occurred, there is a significant drop in dopamine. Those levels will affect oxytocin, prolactin, and testosterone. LDN, when dosed in very close to the time of expected intercourse, may possibly have a beneficial effect with regards to dopamine levels and the following prolactin and oxytocin levels as well. Helpful in arousal and a potent aid to erectile dysfunction, but also its ability to reduce the postcoital depressive state. So after intercourse, there's sort of this little bit of a depressive state due to the drop in dopamine. And this may also be helped with the use of perfectly timed naltrexone, low-dose naltrexone. So in this slide, we are looking at endorphins and sexual function. So there's a couple of components here. It's not just the erectile function, it's also sort of the mood that follows coitus. And we know that LDN has an effect on upregulation of endorphins and endorphin receptors. Endorphins help more with the feeling after sex than the feeling of wanting to have sex or the ability to perform. And they used some animal models using castrated rats, and they had studied these animals with high levels of endorphins and noticed that there was a reduction in testosterone when there was also an increase in beta endorphins. So when you have an elevation of endorphins, you can see a downregulation of oxytocin, an increase in prolactin, and a reduction in testosterone levels. This sometimes results in a wave of sadness or despair, or what they call post-coital depression. And you see less of a desire for sex and less of a desire to bond. So a surge in endorphins can actually help end the act of sex. So this is something that we don't necessarily want to experience when we have an issue with low libido and erectile dysfunction. Because higher doses of naltrexone and LDN work on the body in slightly different ways, we can look at this model again described by Dr. Schuchman in his lecture with regards to dopamine surge during orgasm and then following orgasm a precipitous drop in dopamine, which results in a rise in prolactin and a decline in both oxytocin and testosterone. He refers to this phase as the do not touch me phase of post-coital encounters. It is also a pro-inflammatory state. So with the use of low-dose naltrexone, it can be theorized that the endorphin increase might be tampered to some degree transiently, resulting in a reduction of prolactin, increase in oxytocin, and increase in testosterone. And again, this is theoretical. It's never been tested because there's no research money to go and do a large clinical trial to test this theory. It has been pretty well established that low-dose naltrexone has an effect on inflammation. It actually reduces inflammation, and that's why it's so effective in treatments of autoimmune disorders. And this also may help improve sexual function, because we know inflammation actually can help increase erectile dysfunction in men. So erectile dysfunction is associated with the same factors as seen in inflammation in other areas. You see a rise in HSCRP, you see a rise in interleukin 1 beta and interleukin 6 and tumor necrosis factor alpha. You also see a rise in endothelial prothrombotic mediators such as von Willebrand's factor and tissue plasminogen activator, and PAI1, which is an endothelial cell glycoprotein plasminogen activator inhibitor type 1. That's a mouthful. And also fibrinogen activation. Infections with chlamydia or CMV can also lead to erectile dysfunction. And inflammation acts on NOS as a sort of anti-Viagra, if you will. So the endothelial nitric oxide synthase 3, or NOS3, is an enzyme in the human encoded gene, NOS3 gene, located on the 7th chromosome, or chromosome 7. And it is helpful and responsible for erectile function. And that's the whole sense of using Viagra or similar drugs. It increases NO. So NO is an anti-inflammatory, and anything you can use to increase that will obviously help with erectile dysfunction. In the next couple of slides, I'm going to take a moment to discuss delivery systems for low-dose naltrexone. And if we are going with the theory that timed low-dose naltrexone right before intercourse is the optimal time to administer it, there are certain delivery systems that are maybe better than others. Of course, the standard capsule or tablet can be administered, but also don't forget nasal spray. That is a more rapid delivery system and can be kept at bedside for easy use. So there are compounding pharmacies that will prepare 1% solutions of naltrexone for delivery via the nasal mucous membranes. So remember this if you decide to use naltrexone in treatment of some of your ED patients. Another application that may be interesting is the use of it topically. So there are compounding pharmacies that offer what they call scream creams to their patients, both men and women. The traditional scream cream or gel is a mixture of aminophylline 3%, L-arginine 6% as a vasodilator, and sildenafil, also known as Viagra, at 3.6%. And this is applied topically. Now, with women, they sometimes take out the sildenafil. If you desire to use a modified scream cream, you can ask the compounders to add in naltrexone 1% to the standardized base cream and apply this topically. You can also ask them to compound a plain naltrexone 1% cream or gel for topical application as well. But it may enhance the effects if you use a standardized, what they call scream cream, for the purposes of erectile dysfunction and also to enhance the pleasure of orgasm. I'm going to present a few case studies from my current practice, and the first one will be a patient I'll refer to as patient A. He's a 55-year-old gentleman with a history of essential hypertension and fairly well-controlled diabetes, type 2 diabetes. Past medical history is noteworthy for this kind of slow, insidious onset of erectile dysfunction, which is mild, as well as a decrease in performance during sexual intercourse, and a decrease in libido. As I mentioned before, his hypertension, which is stable, is not treated with any beta blockers or any medications that would enhance erectile dysfunction, and his diabetes is stable on Ozempic and diet control. He had been on low-dose naltrexone for a number of years, approximately 5 years, at varying doses, the highest being 4 milligrams, but he did not tolerate that very well, so it was then reduced to 3.5 milligrams that he has been maintained on and off of for at least 2 years. At one point, however, he had stopped taking his naltrexone at night. For what reasons, I'm not quite sure, whether he ran out or just decided to go off of it for a period of time. And during that period of time, he noticed an increase in his erectile dysfunction, flaccidity during intercourse, and low libido. Within 3 days of restarting, and he started again back at the dose he left off at, which was 3.5 milligrams, which seemed to be the optimal dose for this patient. Within 3 days, he noticed his spontaneous morning penile tumescence had returned. There was more libido and actually better performance during intercourse with his spouse. So we did see at least in this clinical scenario, an improvement in erectile function before and during sexual intercourse. And this sort of correlates with the previous studies I mentioned over the past few years that I presented before. But again, this is a clinical case study of our observations in our clinical practice. The second case I'd like to present is a patient I'll refer to as patient B. This is a 68-year-old gentleman with a history of hypothyroidism. He is very healthy and very conscious of his health and diet. He is a little bit overweight, but he is, if anything, I would have to say a person who has a little bit of nutraceutical polypharmacy. He takes an enormous amount of dietary supplements and has for many, many years, at least 20 years. But I think that you can say that is attributing to his general health and on his advanced metabolic panels and biomarker tests. He does very, very well. He has a pretty robust testosterone level for someone his age. He has a very robust libido and is very sexually active. So he was experiencing some age-related issues with regards to erectile difficulties, not major but minor, and also stamina. His thyroid replacement therapy was adequate and his serum numbers of his thyroid biomarkers were in good order. We decided about a year ago to start him on some LDN, some naltrexone. He was concerned, obviously, with the COVID pandemic and wanted to be on whatever he could, in addition to his nutraceutical bundles for COVID prevention. And he did eventually get vaccinated in early 2021. But prior to that, he wanted some preventive measures. And we had discussed the use of low-dose naltrexone as a preventative and as protection against viruses. So we started him on 1 milligram and then in about a month or so moved him to 2 milligrams, which he's currently taking in the evenings. And when he reported, I just kind of been collecting data on this fellow in regards to erectile function and libido and performance and sexual activity. He quote unquote told me he feels like he's 20 years old again. So here you have a patient, nearing the 7th decade of life, who has some definite benefit from low-dose naltrexone in all aspects, not just erectile function and the such, but all kind of across the board, making him feel like more youthful. I'd like to start wrapping up this discussion with some observations that we need a little bit more research and some good published studies on the use of low-dose naltrexone in erectile dysfunction and sexual disorders. I want to say there's definitely a paucity of published studies and even clinical experience documenting the use of LDN in erectile dysfunction and sexual dysfunction. And both Dr. Shukman and myself are open to those of you out there collecting data to send it our way so that we can start compiling some good data to support the use of LDN and maybe even spark a larger trial. Testimonials are always nice but carry little weight, as those that we see coming out of some peer-reviewed published trials and papers. Observations in clinical practice need to be recorded and presented in case studies much like I've done, but more in maybe a more formal way, and we'll talk about that in a minute. And we can make some assumptions that LDN will work the same and or differently than high-dose naltrexone, but this needs to be validated. Clinicians can record examples and compile cases, but there's just not a large amount of funding for large clinical trials, so I don't expect those happening anytime soon. To help quantify, it might be easier to use the International Index for Erectile Function, the IIEF-5 questionnaire, and there's actually an abridged one as well. And I've made an adaptation here to the bottom. I put pre-LDN and then on LDN and the dose. And this is something that if a patient comes in with a history of erectile dysfunction and maybe has failed other therapies and you wish to try LDN, acquiring this questionnaire before and then during treatment might be helpful in compiling some data and then quantifying it a bit. And again, that was the short form, and this is the long form of the questionnaire. And I'll just flip through these slides. I've given you the URL, so if you desire to go to the websites, you can download these. They're free to download off the internet and use in your practice. So again, these are there's a long form and a short form, and pick one that you're comfortable with that will give data that you're looking for. And then again, I'll mention that Dr. Shookman put the word out during his 2016 lectures that he'd like to acquire data, as would I, for the compilation of more clinical encounters and hopefully assist patients and make this a real thing with LDN for ED. Here's a list of my references for your reference in the studies mentioned, and some sites. The LDN Research Trust site is a great resource and should be used if at all possible. While Dr. Shookman was unable to attend this year's conference, per our discussions in March, he and I are willing to work together in compiling some data on the use of LDN in erectile dysfunction and sexual dysfunction. So use me as a point of contact. My direct email for my clinical practice is drsalibi at carolinaholisticmedicine.com. That's dr.salibi. And our phone at our clinical center, our toll-free number is 800-965-8482. And should you wish to fax any information to us, that's 888-242-0735. Thank you so much.